and now you can move on. Okay.
Okay.
That's the summary. Very important part. Now, the other thing, the most important part of this history is what we call the primary motivator or need. And this is, patients come see us not because they're in pain. People are in pain all the time. Pain isn't you can deal with pain with drugs and modification of lifestyle. But the reason that patients actually come into our office, remember, they don't want to be here. They do not want to meet some new doctor. They don't want to spend any money, and they don't want to spend their day in our office. They don't want to be here. But what motivates them to come in is because their pain or their problem has started to affect their life.
Right.
And specifically, the most common 3 areas of their life that it affects is their work. They either can't work or they're having trouble work, or their sleep. They can't sleep good at night, or their personal care. They can't bathe, dress, cook, or clean. Now, there's obviously more than that. So for some people, they can't exercise. For other people, they can't golf. For other people, you know, it's whatever's important to them. And it's your job to figure out which that is. So for example, we had a gal yesterday that I met, and she came in because she had back pain. And her primary complaint was back pain. But as we talked to her, she had a dozen different problems. And when we summarized it, we said, okay, so you got all these problems. Which one affects your life the most? And she said, well, it's my back pain. And we're like, okay. And so I said, so if you could get rid of any one of these problems, but none of the others, only one, you get to pick one and I can make it magically go away. She goes, oh, my stomach problems. Now, I don't treat stomach problems, but that was really insightful. She would rather have back pain than her stomach condition that she had. And it's important to know that. Why?
Well, because that's her primary goal. That's what's bothering her the most, and maybe causing her more limitations than even her lower back pain.
Definitely.
It could even be the cause of it.
Yeah, that's the one we want to talk about. You know, that's the one that we create our treatment plan around, and that's how we determine our treatment goals. If every time she comes in, I keep talking about back pain and how we're going to get rid of her back pain and make her life better, she might spend some money and spend some time doing what I recommend. But if I tell her, hey, we can get rid of your stomach problems, it's going to cost twice as much money and twice as much effort, she's still going to agree to that because that's what she cares about. Remember, it's just critical that you understand, and it becomes about them. And I see this a lot with chiropractors. They go, well, I like working on neck pain more than back pain. So even though they have more back pain and they want the back pain gone, I'm going to focus on the neck pain. So it's just really critical that you isolate that condition. And that's the first thing I actually put in my chart notes is I'll say, has stomach problems and low back pain. The stomach problems prevent her from doing this and this and this activity. But it's always activity related. And the other critical part of this is the way you tell you've got the primary motivator is that's the one that carries the emotion. So you went through, you build a little bit of rapport, build some trust, connected with the patient, went through, gathered all the information you need, the mechanism of injury and all that. You anchored it back in time so they know that this is an old problem, if it is, and not just a brand new minor problem. And then you figured out what mattered to them, what the goals are, what the need is, how it affected their life. And then when you're done with that, you summarized it for them. You fed it right back to them. They said, man, great job. You really know what's going on. Now, you're going to transition to the exam. And there's a couple of key phrases I want you to use to do this. So you want this is an opportunity to build trust. So after you summarize it, you say, hey, do I have a clear understanding of what your problem is? And they're going to say, yes, Chris, you absolutely do. And then you're going to look at them and go, okay, now look, my job today is to figure out exactly what's causing your pain. And then once we figure it out, if there's something I can do to help you, I'll let you know. Okay?
Okay.
And the reason you want to do that is because a lot of these people have never actually gotten a clear diagnosis. Patients, when they come to see us, they have 4 questions. Do you know what those 4 questions are? Every patient has.
I don't know.
The number 1 question they have is, what's wrong?
Okay.
A lot of times doctors go, you have shoulder pain, or you have a pulled muscle, or you have a torn ligament, but they're not specific. And especially in my profession, they'll say, you have low back pain. I know I have low back pain. What's causing it? Well, and they'll get some dumb, vague do you know what the most common diagnosis? If you go to your MD and say, I have low back pain, and he examines you and checks you out, do you know what the MD's most common diagnosis is for someone with low back pain?
I'm going to guess it's one of 2 things: degenerative disc disease or a sprain strain.
Wrong.
Okay.
75% of the time to 86% of the time, between that range. If you go to your MD and say, I have low back pain, and they examine you, the diagnosis they put in their chart is low back pain.
Or lumbago, right?
Yeah, well, it's the same thing.
Right,
But
yeah.
that's the diagnosis, because they don't know what it is, and they don't tell the patient what it is. So
Right.
when you sit down with them and they come to see you and you're doing this thing, and you go, you know what, you have shoulder pain. My job today is just to be able to, that's my job. I'm gonna figure out what it is for you. Because that's the number 1 question. What is wrong with me? And so you just let them know that. Again, you're telling them, this is what I'm gonna do. And they go, that's what I want. So, that builds enormous amounts of trust. So you don't want to miss that opportunity. It's just called a transition phrase. Hey, Mary, my job today is to figure out what's causing your pain in your shoulder from gardening. By the time we're done, I should be able to tell you exactly what's wrong and how to fix it. And they go, oh, good. That's what I wanted. Thank you. So got it? That's what we call a transition phrase.
Okay.
And I always want a verbal confirmation. And so I always look at them and go, that's what you're here for, right? And they go, yes, that's what I'm here for. It sounds silly and stupid, but it really works nicely. Okay.
Okay.
So, and then we're going to go into the exam. Now, remember, half the time you're already going to have a very specific diagnosis from the chiropractor. And he's going to say, I think it's the biceps tendon, or, a labral tear or something like that. Now, if you agree with that based on the history that you have, then all you have to do is 4 or 5 or 6 tests to see if it is in fact the biceps, and then you'll usually have, you want to make sure it's not the supraspinatus, or it's not a pec major. So, or a neck problem. Right. So your job isn't to do the most thorough exam in the world. Your job isn't to do a massive history to see if they could have heart disease or some other condition. It's to confirm that diagnosis and run through the next 1, 2, or 3 differential diagnoses to rule out a complicating factor. Okay. So, and I usually tell people, if you have, range of motion, and do 4 or 5 or 6 other tests. But when you're doing these tests, it's very important that you do what we call a talk-tell exam. So you use this opportunity to kind of teach them. Say, so the first test I'm going to do, Mary, is first, I'm just going to put some stress on that biceps tendon and see if it's torn. So just curl your arm like this. I'm going to push down. You're flexing the tendon. You're stretching it. If it's torn or damaged at all, this is going to be painful. Don't do something that hurts. And then when they go, ow, you go, yep, there's definitely something wrong right there. Or if they go, man, that doesn't hurt, say, well, I don't think it's the biceps tendon then. Let's check this. So you want to explain to them what you're doing. And it's really important that you do this because you're building credibility. This is a chance to show off what you know. And the other thing too is, well, at least for me, the patients come in all the time and say, oh, I got a pulled muscle, when they actually have a bulging disc or a torn ligament or something like that. And so I actually have to go, okay, I'm testing your muscle. Wow, your muscle worked perfectly normal. You don't have a pulled muscle.
Right.
So I use that opportunity to say, man, your range of motion, this direction is phenomenal. In this direction, it's really, really poor.
Right.
And do you understand why this is going to be helpful later?
Yeah, well, you're educating them on what the structures are that you're treating and what's causing them pain. So you're getting a little bit more specific with them, maybe without them even knowing, just by being, and also you're going to have to cause them a little bit of pain in the orthopedic test. So it's good to warn them.
Yep.
So it's a nice way to do it, reinforcing your credibility.
Yeah, it really reinforces the credibility. The other thing it's going to do nicely is by pointing out everything that's wrong. A lot of times they're minimizers. They come in and they're like, this is a minor problem. I don't know why it's not going away, but this is a big deal. This isn't a big deal. When you start pointing out, this is wrong, your range of motion here is terrible, and this is wrong, you're increasing the severity in their mind. It's very critical that the patient accept your diagnosis. If they don't agree with your diagnosis, they will not accept your care recommendations. Why would I do what he's telling me to do? I don't even believe he knows what's wrong.
Right.
So it's super helpful. So we always do an explaining exam and talk as we go. And any questions about that?
That makes sense.
Okay. Now, as soon as you're done, and of course, you mentioned, hey, sometimes when we're doing an exam, it causes pain. It should cause pain. If it's not causing pain, you're not testing it properly. And you always want to make sure the patient, you predict it. Does it hurt right here? It should hurt right here. And you poke it and they go, ow, that does hurt. You look smart.
Yeah.
So now you're done. You've got the exam. And at this point, you should be very, very sure, 97, 98, 99% certain of exactly what's wrong. You should have isolated it. You had a working diagnosis. You think it could be this, this, or this. By the time you're done with the exam, you should have narrowed it down, right?
Right.
And very confident. You don't have to be 100%. You're never 100%. But you're very confident in what's wrong. And so what you want to do is you're going to sit down with the patient, if at all possible. And this is the big setup. This is the most important part of your day one, is you set the patient down, you do a transition statement. You go, Mary, I want to talk to you about what's wrong.